Thanks very much. And it's really great to see. I'm astounded at how many people are participating. So welcome, and I hope you enjoy this time.
Thank you.
The way that I've structured this is, I'm sure all of us have sat through Zoom calls and just tried to absorb, but I'm trying to make this a little bit more interactive. I can't see the questions, but Lesejo can see them. And if something arises, and I'm going to be asking you guys questions, and you can type in the chat and we'll deal with them kind of real time. As Lesejo mentioned, I used to be the president of the HIV Clinician Society, but about 10 years ago, I changed the focus of my research. I am a researcher, to really focus on the treatment of TB, and in particular drug-resistant TB. No talk from Francesca will be possible without mentioning the breakthroughs in drug-resistant TB. And I know it's a bit esoteric, but please just listen to the bits that fit in with you. I'm trying to make this, as I say, not just me rabbiting on and talking and nobody gaining. So if I pause and ask questions, please participate. I'm going to talk about clinical scenarios. There are going to be some questions, some x-rays for us to deal with. But the first thing that I want to talk about is how much of a problem is tuberculosis in South Africa. So this graph comes from the National Prevalence Survey that was conducted in 2018, yes, pre-COVID. And it had a look at not only, but the prevalence of TB that we see in South Africa. If we have a look at it, we can see that although the numbers are 55, roughly because South Africa in general is a younger population, but roughly 1% of your patients, if they're above the age of 55, is going to acquire TB every year. And the major risk factor for getting TB is, in fact, whether or not you are breathing. It's a very common disease and something that we need to really bear in mind. In terms of the younger patients, this prevalence survey doesn't look at children, so don't ask about children. But overall, this equates to about 800 per 100,000 cases of TB, so just less than 1% within South Africa, which makes us a high burden country. It means that TB has got to be front and center of our minds when we're seeing patients, irrespective of many other things, including their HIV status. So the topics that I'm going to cover is, first of all, how to make the diagnosis. I know it sounds basic, but I'm going to go through what's the important steps in making the diagnosis. I'm going to talk a little bit about chest x-rays, about antiretroviral therapies, because this is, needless to say, a talk of the interaction between TB and HIV. I'm going to talk about what's new on the horizon, because much of what I'm going to say is so old that it is the same as we used to do when I qualified, which was many, many years ago. And then, of course, there's some really hot off the press new stuff about research that we've done in South Africa. And I'm hoping you're going to enjoy that. So where I'm going to start is I'm going to talk about how we've got to be aware of TB. So this is, in fact, a person that I know. She's just turned 50, and she works as a doctor's receptionist. She had an 8-month history of a productive cough. She also complained of night sweats, and as a result of that, she was given the following treatment. Many courses of antibiotics, from Augmentin, Zithromax, anything was thrown at her. She was given hormone replacement therapy because clearly the only reason why a 50-year-old patient would have drenching night sweats is because she was going through menopause. She was given inhaled steroids. She didn't improve. And finally, she was admitted. She was asked to cough in the bottle. She was admitted to a private facility. She was asked to cough in the bottle, and her 3 smears were negative, and that's going to underpin my thing about diagnosis. And finally, the diagnosis of TB was made on bronchoalveolar lavage with a suggestive chest x-ray. So this woman was given a whole lot of unnecessary interventions. General antibiotics do not work for TB. although hormone replacement therapy is necessary, it certainly didn't treat her respiratory symptoms. And it took a long time for this patient to actually be diagnosed as having TB. Yes, she will be all right in the end, but when we go through the X-rays, I want to remind everybody why it is really important that we make the diagnosis TB early. So how do we diagnose TB in the year 2022? Since 2010, we've been using the gene expert system to diagnose TB. I'm sorry, patient a detection of targeted sequences. It uses a real-time PCR, and I've shown the various sizes of gene expert machine. It can also be used for COVID, but it's so simple that even I can run a gene expert. It's a very simple test to do. You get the sputum, you put in a buffer, and off you run. We have many of our laboratories have 4 cartridge gene experts, and some of our laboratories have as many as 196 per machine. The weird thing about this is that this is in the public sector. And the reason I raised the first case was because in the private sector, the gene expert is not used to its full extent. If you are working in the private sector and you are sending your patients for smears, it is a waste of time. We miss many cases. More than half of our patients are smear negative, irrespective of their HIV status. And a smear doesn't tell us whether the patient is sensitive or resistant to rifampicin. In the olden days, so that was pre-2010, we said that you only got rifampicin resistant if you had been exposed to first-line therapy and hadn't taken it properly. But that's not in fact true. About 80% of our rifampicin-resistant cases are transmitted, meaning that they stood in the bus next to, caught a train with, went to a shebeen with someone who had rifampicin-resistant TB. And we want to detect and treat TB appropriately with the correct treatment as soon as possible. And roughly 2% of the patients who present with TB in South Africa are rifampicin resistant. We do have treatment for them, which I'll describe as time goes on, but the bottom line is that we want to find them straight up and start them on appropriate therapy, not wait for them to fail first-line therapy. Yosego, anything in the chats that I need to respond to?
Yes, we do have a question, but it's not necessarily linked to your slides. So I think maybe we can deal with it a bit later. Yeah.
Okay, but if something pops up, you'll let me know.
Yes, if you can also just check your
so
network.
The gene expert is, so I'm staying in a hotel and we've got load shedding. I'm connected through my cell phone.
Oh yeah,
so
sure.
I'm really doing all that I can, but this is now up to end-to-ends to sort it out. So what does a gene expert do? First of all, it's more sensitive than a smear. To be smear positive, you need 10,000 organisms per field or colony forming units. Culture detects 5 per mil. And the Gene Expert Ultra, which is the machine that we now use, detects at about 30. So it's much more sensitive than a smear. The next thing is acid-fast bacilli, whether they're Mycobacterium tuberculosis or not, they look exactly the same under the microscope, whereas a Gene Expert speciates. And you know, so what you're seeing is actually TB or it's not TB. It gives rifampicin sensitivity. It takes 2 hours. And although it's 2 hours in the laboratory, it actually takes, most gene experts in all of our provinces are back within 48 hours, which is much quicker than a culture. And it's also free in the public healthcare system. And my advice is, even if you're in private, if you suspect someone has got TB and the medical, and I think that it really does our patients a disservice if the diagnosis is attempted on anything other than a gene expert. Of course, I might say something different later when we've got other diagnostics, but this is where we are in May 2022. So we've talked about the diagnosis of TB, of pulmonary TB, the kind of most common presentation. The patients who present to our service complaining of chest, of cough, weight loss, fever, or night sweats. But what we do know, certainly if you're working in South Africa, is that there are some challenges. Patients with advanced HIV can have extrapulmonary disease, they can have porcibacillary disease, or they can just be plain too sick to cough up for us. And of course, those are the patients we want to make the diagnosis as rapidly as possible. If you don't diagnose TB on time, it leads to mortality. And if you didn't know that, you're perhaps on the wrong Zoom call. And of course, late diagnosis and late treatment means that there's a possibility of more lung damage. And of course, when we add to that the fact that untreated TB is highly infectious, we really want to make the diagnosis as quickly as possible. So we do have a new, well, relatively new, but it's now been incorporated into our diagnostic algorithms.
Colleagues, it seems like we might have lost Dr. Conradi due to the network. Let me check on her. I'll get back to you. Sincerest apologies.
Can you can see my slides?
Yes, we can see your slides. Thanks, Doc.
I'm sounding like a first timer. Can you see my slides? But I apologize, we have had bandwidth issues. So we're talking about the LAM and where it can be used. So it can be used particularly in advanced HIV disease. And advanced HIV has a clear definition. It is someone who's got a CD4 count of 100, or anyone who presents with a stage 3 or stage 4. TB is, but if someone is presenting with any stage 3 or stage 4 condition, and I think the most common one that we'd be on the lookout for is cryptococcal meningitis. And then all children who are not on antiretroviral therapy under the age of 5 are considered to have advanced HIV disease. So this is the place where we can particularly use the LAM. In addition, we can use it in seriously ill patients. So we should be using it almost as a screening test when patients present to casualty. If they are breathing at a rate of more than 30 breaths per minute, they've got a temperature more than 39. Yes, I do know that there's COVID around, but I think that there is no harm in asking someone to pass a specimen of urine and to exclude TB. If they're tachycardic with a heart rate of more than 120, if they are unable to walk on their own, of course, these are HIV-infected patients. PS, COVID can occur in TB patients as well. Someone can have both. So the new South African guidelines for the use of LAM, it's clear for the inpatient settings. So we recommend the use of LAM, and I would put it really back to the casualty, to when patients are admitted. If, irrespective of their CD4 count, but if they're sick enough to be admitted, you should do a LAM. If they've got symptoms of TB, you should do a LAM, irrespective of their CD4 count. But don't forget that this is not an excuse to practice bad medicine. At the same time, you should do a sputum molecular test for TB. So the gene expert will tell us, are we dealing with TB or not? And the next thing it'll tell us is it sensitive or resistant to rifampicin, a very important consideration. I hope that the internet is stable and everyone is keeping up.
Yes, thanks, it's better. Thank you.
Great. I mean, there's nothing I can do except for phone the chairperson of ESCOM and ask him to give us a break. In the outpatient setting, to say in terms of the use of a smear. It doesn't 100% rule it out, but a positive test means that your patient has got TB. So please bear this in mind. It is available both in the public and the private sector. And please bear it in mind when you're struggling to make the diagnosis. Next slide, please. So I've mentioned the limitations. It doesn't tell us whether a patient is sensitive or resistant to rifampicin. The test needs to be conducted properly. So even though it can be done at the bedside, you need to make sure that you've done the test correctly and that the test has been correctly stored so that we don't get any false tests. If the bar on the test is really strongly positive, it doesn't mean that your patient's got lots of TB or high bacillary burden. It just tells us that their kidneys are excreting part of the TB bacillus and we're picking it up. And if the test is not valid, it doesn't mean that it's a yes or a no, it means it's invalid. And you can only do, at this stage, you can only do a LAM on a urine specimen. So it's got caveats, but please don't forget to do this in the really ill patients that are presenting to your casualties and to your practice. Next slide, please.
Yes, before we proceed, there was a question about gene expert after treatment. So a patient who has just completed TB treatment, what is the right timing to use gene expert for diagnosis?
Yeah, so the first thing is gene expert is used for diagnosis and not monitoring. And it is also quite, so the gene expert can remain positive with drug sensitive and drug resistant TB for up to a year after a patient has completed TB treatment. So it means that we've got to be pretty careful about how we make the diagnosis. And patients who've had previous TB often have ongoing pulmonary problems. So they come to the clinic, someone does a gene expert, it's still positive, so they just put them back onto TB treatment. The diagnosis of TB, a relapse or reinfection, so less than a year after they've completed their TB treatment, is actually made on clinical signs and symptoms and culture. So this is the time, if someone comes back to you 6 months after finishing their TB treatment and they say, I'm coughing again, if a gene expert is positive, particularly if it's the same pattern as their first, it might well be that they've got TB. But the ultimate diagnosis is made on culture. So we grow the organism to see whether or not this is active TB. It is the drawback of the test because the gene expert doesn't look for growth, it just looks for DNA. So that is one of the problems with it, but it's about a year.
Okay, thank you.
And in terms of starting TB treatment, particularly with drug-sensitive TB, it's not a big disaster if you start too many people. It's much more of a disaster if you don't start enough. So, if you feel that the patient has got TB, their gene expert is positive, restart them and wait for the culture. And then the culture will come back at 6 weeks. If it's negative, you can assess the clinical response. If the culture is positive, well, then that's the end of the story. Your patient's got TB again. Okay, so the next 2 slides are very, very boring because they have been exactly the same. If you could go back, sorry, I went a bit fast. So The treatment of drug-sensitive TB has remained the same since I qualified. And I qualified in 1988. Don't worry about the sums, I'm 57 years old. So it's exactly the same. The only change has been, instead of taking 4 different medicines, we now co-formulate them. And that is probably the least amount of changes in a treatment that has occurred in any field. When I qualified, there were no antiretrovirals registered. And now we've got a gazillion of them. The treatment of hypertension, they just started to bring in ACE inhibitors. I know the young people on this call are smiling. But so the treatment of virtually everything has changed, but not TB. It's remained exactly the same. We give 6 months of treatment, 2 months of HREZ, so ethambutol and PZA, and then we just give INH and rifampicin for the last 4 months. So the first thing is, what do we do if someone gets an adverse drug reaction to one drug? And by far and away, the most important drug in our drug-sensitive regimen is rifampicin. So what if they get an ADR? Fortunately, ADRs to rifampicin are uncommon, serious ADRs. And almost the most common ADR is liver toxicity, and it's usually not due to rifampicin, it's usually due to PZA. But the other thing that that we need to bear in mind is that we are not making the diagnosis of INH monoresistance at all. If someone is rifampicin sensitive, we know from epidemiological work that roughly 15% of them are INH monoresistant, which means that we're treating our patients on only one drug for the last 4 months of their treatment. And we need to start finding these patients. There is a treatment algorithm for them. We continue HREZ even in INH resistance. But what we do add is we add a quinolone and we extend the regimen for a minimum of 6 months. So we would do something if we knew it, but the truth is we just don't know. And that's why often you see them march. You see someone who presents with drug-sensitive TB, they're cured. They present with drug-sensitive TB, they're cured. And the third time it's rifampicin resistant. So even when patients are doing exactly what we tell them to, the treatment can fail. Good news, of course, we always have got to go for the good news, is that the GeneXpert machine has now registered a cartridge for XDR. And XDR means, in this case, resistance to a quinolone or an injectable, but it also picks up INH resistance. So it's an expensive thing to do, but we'll probably be incorporating this cartridge into our diagnostic algorithm in the next couple of years. And then we can find these INH monoresistance. Next slide, please. So what we've got to warn our patients about is when I put you on rifampicin, your pee is going to go the same color as OROS. Do not be alarmed. The drug-sensitive TB treatment can cause redness and itching of the skin, particularly in the sun-exposed area. It can cause nausea, diarrhea, loss of appetite, mild upper abdominal pain, mild pain in the joints, mild headaches, and sometimes can cause sleep disorders and depression. It sounds like a quite extensive list. But what I have found in my many years of practice is that the best TB treatment that's available is rifampicin, INH, ethambutol, and PZA. So if at all possible, what we want to do is we want to keep our patients on that regimen, which means we often have to nurse them through the side effects. I would rather take 6 months of this regimen than the complicated regimens that we use for drug-resistant TB. So, you know, really we need to warn people that side effects are coming and encourage them that this is only going to take 6 months. Just bear with me, bear with your funny colored saliva and sweat. You know, it's going to be fine if you can just manage to take this. And I think that we tend to interrupt treatment too easily, but try and encourage people to go through this as opposed to then starting to go on less efficacious and more difficult regimens. Next slide, please. So This is a talk about HIV, so of course I've got to talk about when to start antiretroviral therapy. It's very sad to me that even in the year 2022, people are presenting to our HIV treatment programs with CD4 counts less than 50. Treating for TB is, treating HIV, we've got a wonderful antiretroviral regimen in the form of TLD with lower side effects, and yet many people are presenting late. And predominantly it is men who are presenting late. And if your patient has got a CD4 count less than 50, you need to start your patient drug sensitive or drug resistant on antiretroviral therapy within 2 weeks. Otherwise, you can start within 2 months. And I think it really depends on the flow of your clinic, how sick the patient is, what we're concerned about starting the regimens too close together. So TB treatment and antiretroviral therapy is immune reconstitution syndromes, which are really more of a pest than really cause mortality. So, obviously a CD4 count above 50, you can leave until the end of the intensive phase, or you can start at the end of the first month and be guided by your patients. I know it's a bit of a soft guideline, but it really depends. We don't really want people to come back for treatment. So in patients who are antiretroviral naive, we use TLD. I sometimes think that the only antiretroviral regimen I know now is TLD. But if we are treating drug-sensitive TB, we're giving rifampicin, so you've got to give an extra dose of dolutegravir at night. It can't all be taken at the same time. It's got to be at night. If the patient is exposed to NNRTIs and unsuppressed, either because they have been lost to the program or because they have developed resistance, we need to treat the HIV, and our current guidelines say we need to use AZT, 3TC, and double dose lopinavir and ritonavir. I don't know if there's anyone in the audience who's been successful with this. It's AZT causes lots of short-term side effects, including nausea and vomiting, which is a problem with TB treatment. And double dose lopinavir, ritonavir, it's the correct thing to do. However, it is a really difficult regimen to take. And what we really need to do is to suppress that viral load. We need it to be lower than the level of detection as quickly as possible. So what I want to talk about, if we can go to the next slide, is there any alternative that we can use? So at the moment, our second line regimen, if your patient was on an NNRTI, so was on efavirenz, then we use dolutegravir. If the patient was on a PI, then you use dolutegravir. And what we really have done in our second line patients has recycled the nucleoside analogs. So we've gone from tenofovir, lamivudine, or tenofovir emtricitabine to AZT and 3TC. Is that really necessary is the question that I want to ask. And what I want to do in the next slide is to talk about whether this is necessary or not. So in the next slide, we're not talking about a policy change, but something that we need to consider. In a wonderful study done by one of my HIV heroes, Nicholas Payton, they looked at how whether or not we need to recycle nucleoside analogs. And this study was called NADIA. It was presented about a year ago, I think, at the AIDS conference. But if we have a look at the next slide, what did they actually do and what did it mean? So it wasn't conducted in South Africa because we, at least in theory, detect failure of a first-line regimen quite quickly. We don't actually, but at least in theory we can because our HIV program is supported by a viral load. But so what they did is that they looked in countries where they had failed an NNRTI and then had a look at two approaches. I am a clinical trialist, so I love these pictures of how they do the studies. But what they looked at is, what if we recycle the nukes or change? So we give dolutegravir plus AZT3TC or plus tenofovir lamivudine, which is a much easier regimen to take. And what if we don't change the PI? So if we have a look at the study diagram, which is on the next slide. So patients who had failed an NNRTI, even with established, so without knowledge of resistance, and we know that anyone who fails efavirenz has got resistance, were randomized to either go onto a PI-containing regimen. In this case, they used darunavir, ritonavir, or were randomized to get dolutegravir. And then they were further randomized to get either, someone says the slides are not being shared.
I think they should. I think it's probably the network on their side. I will
on
reply
their side.
to them. Yeah.
Okay.
Yeah.
So then what they also looked at is, what if we keep tenofovir and lamivudine? What if we swap out to AZT3TC, which we all know is a horrible drug?
Let me reshare. Let me reshare, because if you can see it from your side, I would be expecting everyone to see it, but I'll just reshare.
Reshare. But we all know from long-term use of AZT that it really is not a nice drug to take. And it causes the stigmatizing side effect of lipoatrophy, which is something our patients really want to do. So the patients were randomized to one of these four options. And what I'm going to present on my next slide when they come up is what was the outcomes of the study. So if we go to the next slide. In a nutshell, again, as a clinical trialist, I love these pictures. But in a nutshell, irrespective of whether they were given AZT or 3TC, or whether they were given dolutegravir or darunavir, the success rate was the same. Of course, this is really short-term data. This was only 48 hours after now I'm talking like TB. It was only 48 or 52 months after. So we don't know what the long-term consequences are. We do know that double-dose lopinavir, ritonavir is very difficult to take. So one thing that we're going to be revising in our HIV guidelines is whether or not we recycle the nucleosides or not. Next slide, please. And again, when we look at the nucleoside changes, the outcomes were about the same. So in this difficult to treat population who got established resistance to the nucleoside analogs, they still suppress on a combination of dolutegravir, lamivudine, and tenofovir. So the reason that I'm pointing out to this is I'm not suggesting or advocating yet that our guidelines have changed, but just remember what a burden it is to take double-dose lopinavir, ritonavir. And we know that if you don't take adequate antiretroviral therapy, your viral load is never suppressed. It's a thing to consider when you're treating our patients. And this was a very pragmatic trial done within programs where the detection of resistance is very low. So just something to put in our thinking caps, or to put into our heads and put on our thinking caps, whatever the metaphor is. Next slide, please. So now what I want to do is I want to ask people in the audience what they think of this X-ray. Do they think this patient has got TB, yes or no?
Yes, colleagues, please type in the chat box so that we can see your answers. Do you believe that this patient, based on this X-ray, does the patient have TB? You can just type there.
I love these answers coming through. They're coming through.
I'm not seeing any no's so far. I wonder what we see.
Yes.
All right.
So this is a patient who's enrolled in a clinical trial with me. She's culture positive for rifampicin-resistant TB. And if you have a close look at it, what you see is a large cavity, what's really a bullous in her right upper lobe. She was smear negative, but culture positive. And this is an obvious case of someone who's likely to have TB. And if this was the only information that you had, I would start this patient empirically on TB treatment. In this case, it was a patient who is culture positive for rifampicin-resistant TB. If we have a look at the next slide, also a chest X-ray. So, do you think this patient in a remote area and you've given this X-ray as a radiologist and you ask, do you see signs of TB on this X-ray?
Cindy is not convinced. Cindy is not convinced. Smogile says yes. Yo, it's mixed this time. It's yeses and nos and possible and not typical, not really. So I think people are just somewhere. Someone says miliary TB. Someone says unless GXP is positive. Someone says unless the CD4 count is low, not typical. Colleagues, yes, keep them coming. Dr. Conradi just lost the network. I know that she will join in. I will summarize for her your comments. Yes. Dr. Conradi, are you able to hear me?
Yes, I can, and you can't say South Africans aren't. We don't think. So what are the second word?
So just to summarize, it's mixture. Some people said miliary. Some people said yes, possible if the CD4 count is low. Someone said pending the gene expert results. Most people are in between, you know, but it's a mixture of yeses and no. So it's not as obvious as the first one, I think. Yeah.
Reason why I put it up. This patient is culture positive for the CD4 count was low, so it kind of fits in with the clinical picture. But this is not a chest X-ray that you would say this patient definitely has TB. So, which is why we combine our clinical findings with our radiological and microbiological findings. Next slide, please. Yes. This patient no longer walks the earth.
Yeah. Yeah. Colleagues, TB or no TB? I see a big yes.
Yes.
From Lubovia. I see a lot of yeses. Someone says yes, so
yes.
I guess. Next, yeah.
So the story of this patient is that he's culture positive for rifampicin-resistant TB. But he'd had numerous previous episodes of rifampicin-sensitive and resistant TB. He doesn't have a lung really on the left-hand side. And this is the consequences of untreated or lately diagnosed TB. Even if we were able to cure this patient, which unfortunately we were not, this patient will become a respiratory cripple and will end up being oxygen dependent, would have ended up being oxygen dependent. You can't really tell whether this is active disease or not. You can see a couple of fluid levels. So it could be that he's got bronchiectasis or aspergilloma or something. But this patient has got TB, culture positive rifampicin-resistant TB. And I just put it as a sobering thought is that the billboards, everywhere say TB is curable, and it definitely is curable. But we've got to remember the consequences of not finding the diagnosis quick enough. This patient did not survive. Next slide, please. Okay, so that's our past history. We're using at least 30-year-old regimens in the same thing. We just add them all into one pill. But what's new in the drug-sensitive TB world? And the good news is that there is some good news. There have been a number of clinical trials that have been conducted to see if we can't shorten the regimen. What we've done with TB is we've adopted both drug-sensitive and drug-resistant TB, is that we've adopted a very much one-size-fits-all, that everybody gets the same treatment. Some people are cured with 2 months of HREZ, but we treat them for the 6 months. And please be clear that I'm not saying we should change that yet. But not all people need 6 months of therapy, and occasionally people need even longer. But we've been searching for the holy grail, which is a new treatment regimen that's a little bit shorter. I think that COVID taught us a number of things. First of all, the human race can be quite selfish. And the other thing is that we want to get our patients treated and out of our healthcare facilities as quickly as possible. So what is new on the drug-sensitive TB treatment realm? Next slide, please. So really interesting study, and please, Letego, if you could share these slides broadly, because I know that this is really tiny, but I wanted to quote it from whence it comes, and it comes from the New England Journal of Medicine. What they did is that they randomized a number of patients, about 2,500 patients, to get standard TB treatment or to get rifapentine plus moxifloxacin for 4 months. So although it's only a 2-month, if you can zoom in, please do it. But it's only a 2-month reduction. For the first time in the history of TB, we have a regimen that can be used for only 4 months. The place where the data is lacking is there were not that many HIV infected patients. So of course we now need to conduct the trial in South Africa to look at what the field says in terms of HIV infection. And then also, we don't know if this regimen works in pregnant women or not. So if a woman is diagnosed in pregnancy, pregnancy changes the way that we handle drugs. It changes the metabolism, and pregnant women are more at risk. But at least we're on the pathway to developing a new treatment regimen. Our current chief director for TB is Dr. Norbert Njeka, who has really changed the face of drug-resistant TB. And he is aware of these findings. So don't be surprised if we start to see the rollout of this rifapentine, moxifloxacin containing regimen in our program in the next 2 to 3 years. And you can say, I heard about that one from Francesca. Very, very interesting work.
Great.
The drugs are not co-formulated. Sanofi's not making enough rifapentine, so there are lots of challenges still. But at least we're on the pathway to finding a shorter regimen. Next slide, please. So no talk on TB would be complete if I am talking, if we don't discuss the issue of rifampicin resistance. And I know that the things that cause doctors and nurses to panic is a gene expert, Mycobacterium tuberculosis detected, rifampicin resistance. They cannot get that patient out of their facilities quickly enough. The other thing is, of course, a COVID test, but we've got used to that. And we've adopted quite a like a panicky response. And one of the many things that I'm glad for with COVID, I got to spend more time with my children. But in addition to that, the other thing that's really good is we've started adopting the use of masks in hospitals, in healthcare facilities, even in shopping centers. And I think that will have an effect on transmission. But, you know, I don't want to get TB, either drug resistant or drug sensitive. I just showed you a shocking X-ray of what happens to people who've got TB. So people panic when they see rifampicin resistance, and they know that there's something about, I don't know, an injection, but they want the patient out. And they will refer to either a center of excellence or a referral hospital. We first tumbled to the fact that there was a problem with rifampicin resistance probably between 1985 and 1995, that not everybody was being cured, and then we could see the development of rifampicin resistance. And the research that's been done in this particular field has been even further behind until quite recently. These are the WHO guidelines that came out in 2009. They're old, so things have changed, but it was all based on expert opinion, and expert opinion is usually quite fearful. You know, we see something, we panic, we want to throw a lot of medicines at our patients. It included the use of an injectable agent, and many TB patients have a very low BMI. So you have to give an intramuscular injection for 6 months to someone who's got not a proper sized bottom like I have, but really, they are really, you know, it's a really difficult thing. And in addition, we made a third of our patients deaf. And losing your hearing is a profound disability, whether you're old or young, it's profound. So as a result, I started to work in drug-resistant TB because this was clearly an area that needed some changes. HIV clinicians, we are brave, we want to change things, and we know our guidelines change frequently. So what has happened since then? If you go to the next slide. Sorry, that's just the highlights.
Sure.
So then this is really, and I'm stressing it because this is part of the good news. This was a trial that was conducted in South Africa only, looking at what we've called highly resistant TB. And we kind of coined that term because we meant it to include a bunch of people for which rifampicin resistant TB treatment was failing. The first is patients who had extensively drug-resistant TB, and at that time the definition was not sensitive or resistant to both a quinolone and an injectable agent. It has changed, but I think that I won't go too much down that. But it was used for patients with XDR, people who weren't responding to standard NDR TB treatment, and people who were intolerant, and that was largely driven by the injectable agents. I've cut and pasted the article so that you can be 100% sure in your mind that there are no typographical errors. In this study, which was called NICS, 90% of our patients were cured. So that's similar to what we're seeing with drug-sensitive TB. And at the time when we began this research, what we did is that the mortality rate from extensively drug-resistant TB was about 50%. And here we treated a cohort of 100.
Apologies for the network, colleagues. It will come back. Just be patient with us tonight. Thank you. Yes, it will come back. Thank you, Esther. Thank you for that. Yes, she's reconnecting. Thank you.
Sorry, I'm back. I keep reconnecting, and there's really nothing else that I can do but keep connecting to my cell phone. And I hope that my storytelling is making you excited. But in this regimen, what we did is we found that 9 out of our 10 patients were cured. But in the bottom line, you can see that many of our patients had adverse events. And the most common adverse event was peripheral neuropathy. We are well versed in the treatment in peripheral neuropathy. We know it from our old STABUD days. We know it from our advanced HIV infected patients, from INH, from a whole bunch of things. So we know about peripheral neuropathy. And in this case, about 80% of our patients got some degree of peripheral neuropathy. It almost entirely resolved. And that adverse event, it falls squarely onto linezolid's shoulders. So it's linezolid's fault. And we used a very high dose. I know that linezolid is not a commonly used drug, but we used a dose of 1.2 milligrams. So a very, very high dose. Enrollment at 109 patients, which is a very bizarre sample size, and then moved on to the next slide, please. The next trial, which was a trial, they name these things funnily. It was called the Xenex trial. And what we did on the Xenex trial is that patients were randomized to 4 different doses of linezolid. So we used the same backbone of bedaquiline and pretomanid, but people were given 4 different doses of linezolid. 600 milligrams, 1.2 milligrams for 2 months, and then 600 milligrams for 2 months. We released these results at the AIDS conference, I think, last year, and it has resulted in a rapid communication by the WHO. And I'm not joking, this rapid communication came out on the 1st or the 2nd of May. So from research work done in South Africa, we have changed the face of the treatment of rifampicin-resistant TB. We're going to start to be using in our program, and we have already started to a certain degree, this 3-drug all-oral regimen, bedaquiline, protomimid, and linezolid. And all the indications are that we can expect a 90% cure rate. This is a massive breakthrough, and it's really, it's a combination of having a very research findings. And South Africa leads the way by far in this. We have used more bedaquiline and protomimid than all the other countries in the world put together. So it's great to be working in this this rapidly changing area. This is available, and I can share the link to it, but really a tribute to our South African guidelines. The next thing is also published on Monday was a paper written by Norbert and Jeka and myself, and then the rest of the people on the committee who serves on the National Clinical Advisory Committee. South Africa pioneered another short course regimen. One of the drugs we used to use was an absolutely awful drug called ethionamide.
Colleagues, thank you very much for understanding our network challenges today, but I do know that you are
showing that we can use an all-oral regimen. It's a very South African regimen, and this has been endorsed by the WHO. So way to go, South African National TB Program. Fortunately,
positive.
It's very, very positive. I think although what we have seen is we've seen a decline in the number of rifampicin-resistant patients presenting to our program. Of course, the last 2 years are due to COVID, but because we are treating rifampicin-resistant TB so well, and we are really world leaders, that is decreasing the amount of transmission, and so we're seeing less people presenting. So these are two, I only sent my slides this morning because I wanted to incorporate these changes, which is a very exciting change. Watch the press. It will be announced pretty quickly.
Exciting. Thanks for sharing, Dr. Conradi. Yes.
Okay, so in summary, and then I'm going to have a look at the questions, is that, so, sorry, this is a summary of the results, that our regimen is now accepted by the WHO. I'm not sure what other countries are going to do. I just know that what we do is that people who are rifampicin resistant get a short 9-month regimen. Although it's with 7 drugs, it's a much better regimen than what we used to do. So in conclusion, in my final slide.
Oh, all right.
You're so caught up in the story.
Yes.
You know, when I talk to doctors who work, in fact, we are doing some work with Ukrainian doctors. The incidence of rifampicin-resistant TB, it's much more common in Eastern Europe than it is. I haven't heard from them for a while, which is, we all know why. But you know, TB, in the main, it occurs in impoverished communities. It occurs with in people who have little resilience, and COVID has made it much worse. If I tell someone that they've got extensively drug-resistant TB and this is not their biggest problem in life, you know what, they've got some pretty big problems. So what we want to do is to enable successful TB treatment for the majority of our patients as quickly as possible, bearing in mind that often the reasons they can't complete treatment are things beyond their control. They don't have enough food to eat, or substance abuse is common amongst our patients. And we've got to work out ways to support people through that. Personally, I would pay people to stay on the TB treatment because I think the long-term benefits of them being fully treated is much more than the cost. And I know that that's a contentious issue. I don't know how the audience has divided out, but the vast majority of patients in South Africa are treated by the nurses. So they get a gene expert, rifampicin resistant or sensitive, and they're referred to the TB program, which means that we have to have really safe regimens and clear pathways of referral. If my patient gets sick, what do I do with them? How do I send them back to where they came from? So clear referral patterns. The nurses do a fantastic job with the treatment of TB because what we've done is we've made it very clear you do this investigation at this time, and nurses, even in this country, start patients on rifampicin-resistant TB treatment. But we've also got to be cognizant of the fact that many of our patients don't get, they don't even get a chest X-ray when they're diagnosed with TB because that would mean another clinic visit. So we don't even know what the chest X-rays look like. So we've got to adapt our work in TB to accommodate the fact that many of our patients have many other struggles. What research needs to be done? Yes, I am a researcher, but what research do we need to do to support our national TB programs? We need short treatment. We need it to be as short as possible. We even need to see if we can't go from 4 months to 2 months. There is a way of working out how someone is going to respond to TB. We look at the smear status and the chest X-rays, but the truth is many patients don't even get a chest X-ray. So we've got to work out ways that we can upload chest X-ray data. Maybe we can, I don't know, but we need shorter regimens. We need them to be as safe as possible. We need minimal monitoring. Bedaquiline has to be monitored with ECG, and that's a challenge because ECGs mean you've got to have uninterruptible power, which clearly we don't have in Port Elizabeth, that you've got to have ECG paper and leads. So we need to make it as safe as possible. And we need to rapidly diagnose resistance. We need to diagnose resistance to rifampicin, INH, the quinolones, and bedaquiline, our new wonder drug. The rate of resistance in our country is about 2%. It's not a big surprise that we need to find them quickly and start them on treatment, on appropriate treatment, so that they don't spread the disease. I have a father and a son pair who's on a clinical trial with me. The son got bedaquiline resistance and he gave it to his dad. So this is a transmissible infection. And we need to find them quickly, not to stigmatize them, but to start them on appropriate treatment because we do have treatment options. I think that that's the end of my talk.
Yes, thank you, Doc. Yes, so thank you very much, Dr. Conradi, for this presentation. I think looking at the chat, it's buzzing and people are very empowered and they are happy. There's a number of questions, particularly which were shared on the chat, which you might not see because the chat keeps on going up. But I've also kept track of the Q&A. Very early on, when you started to present, there was a question around the role of tracers and the fact that what happened to that program and how important is it today in terms of the community engagement, community tracing teams and education? I don't know if you would like to talk about the community element of TB and its importance. Yeah.
So if I was President Cyril Ramaphosa or our current Minister of Health, I would develop SWAT teams, so a really vigorous contact tracing, because that goes for drug sensitive and drug resistant TB. Children certainly catch TB in their homes. So if there is a smear positive adult and their kids there, that's where you're going to find them. So the lessons that we learned from COVID is we can do contact tracing. It's kind of fallen, TB contact tracing has been, it's actually, certainly in Port Elizabeth, it's left to the NGOs. So, and NGO funding, as we know, can be, can be fickle. It can come and go. So it means that it's not a constant. But we need effective contact tracing. Everyone who's got TB breathed in their TB organism, well, almost everyone breathed in their TB organism from someone in their community that had it. So we should have much more active contact tracings. In the States, if a doctor says suspect TB, you know what? That patient cannot leave the hospital until TB is either being included or excluded. If the diagnosis of TB is made, then the patient, I'm not saying that this is correct, but the bottom line is that they cannot leave the hospital. And we need to get that rapid diagnosis of TB so that we can find people much earlier.
Great. So when are you, which political party and when are we voting? But let's not get into that. Yes, there was a number of questions about the neonates who are born and exposed to TB. There were issues around the prophylaxis, the BCG issue. I'm not sure if you, at the high level, you are able to just give advice at that level.
So I see the one question from Zukiswa, and she's asking about an HIV-exposed neonate with a mom diagnosed with PTB. So if the child looks well, then either way, we defer the BCG until 6 weeks. And start immediately on INH. It's my advice to all women who've got a neonate, if possible, they must try and breastfeed. And if the mom is smear positive, or in fact, whatever the mom is, she should wear a mask while she breastfeeds her baby. Sleeping with the baby, it's up to her really. And also spend as much time, particularly when the weather is not too bad outside, to try and decrease transmission to the infant. But what should happen is that the child should be started on INH and the BCG given at 6 weeks.
Yeah, so there was a similar question, but then the twist was the issue of if the mother is on drug-resistant TB, is the approach the same, or what would be the key things to worry about?
Exactly the same. So the rather sad thing about the treatment of pregnant women and women who deliver is that there's almost no research done with them. And we know from our HIV experience that, well, from experience in general, that drugs are handled differently by pregnant women. We can't give them anything that gives them nausea and vomiting because they already have nausea and vomiting. But so the study that I'm conducting in PE, we're actually enrolling pregnant women as well to get further information. But the advice is exactly the same. Wear a mask. Once the baby is born, exclude active TB. A child with congenital TB they usually are small, hepatosplenomegaly and anemia. They've got no signs of active TB. We usually will give the baby INH because in some cases it works, and encourage breastfeeding with infection control, but we do exactly the same. And give me a year or two and I'll give you some better answers as to the pharmacokinetics, but we still advise exactly the same.
Yes, and there were two similar questions talking to symptomatic patients where gene expert LEM, remain negative, but the X-ray is suggestive in a COVID patient. And maybe you can just highlight, TB, COVID, PCP, how does a clinician decide, in terms of the approach? Because these three conditions in the context of HIV may present similarly. Should we be testing everyone for TB, COVID, and maybe initiating PCP treatment until we exclude? I don't know what your advice would be to clinicians. Yeah.
So I think that an HIV-infected individual, particularly one who is not on treatment, who presents to our services with a CD4 count below 200, we do what we need to do to try and exclude the diagnosis, but there is no harm in initiating TB treatment. I don't think that anybody should die without the benefit of being given a rifampicin-containing regimen. So, you get this patient presenting to your facility, they've had a chronic cough, now they're acutely ill, they're desaturating. What is it? Throw the book at them and apologize later. So give them everything that can potentially help. And it doesn't really, if they don't survive, then we don't know what it was. But if they do survive, then at 2 months you go, let me revisit my decision. Did they, how did they respond to treatment? Do I think it's still TB and do I continue or not? But, and they're very difficult patients because they're presenting sick and we've got very little time to sort of hum and haw about what to do. So I would really, I would err on the side of giving TB treatment. So what if we're wrong?
It's life-saving. It's life-saving.
That's
So there's a similar scenario, but now in this instance, we're talking about asymptomatic defaulter whose LAM test is negative. You are awaiting your gene expert results. Can we start RIFA4 in the meantime? Or,
yes.
Yeah.
So, well, I think you need to put the story together. So
yes.
if you x-ray the person's chest and they've got obviously chronic lung disease and nothing, it's not an acute kind of picture, then wait. But if you're worried about it, it takes much more, sorry to say the word balls, it takes much more balls to stop someone's TB treatment than to start. And again, it's not the end of the world if you if we are over treating TB. But what I have seen is a number of patients who've got chronic lung disease who are started every single year on the basis of a gene expert on TB treatment. And when someone finally looked at it, they actually had an aspergilloma or bronchiectasis that was the cause of their disease. And it's really difficult in the short term to pick out the two. The thicker someone is, the more likely we are to start TB treatment. Never excluding good clinical practice, and I'm not referring to research, that we do all the investigations. So we wait for our cultures and all of that. We do what we have to, but we can still initiate therapy.
Yes. So Dr. Conradi, in the context of, because I saw a question, it's probably based on the timing of ART initiation for TB patients, but this one refers to a patient who has started on ART and then 2 days down the line, the results come back and it's a TB case. What happens to the ARVs? What's the recommended approach in that scenario? Yeah.
What I would do is I would just initiate them on TB treatment. If they're on a dolutegravir-containing regimen, obviously we give the second dose. Or if they were started on efavirenz, I want to know where that was because those doctors are being naughty. But I would just carry on. I mean, they were sick enough to present with TB. I wouldn't interrupt antiretroviral therapy. Of course, if we've got any suspicion that there's tuberculous meningitis or cryptococcal meningitis, that would make me interrupt therapy. But there's no, we kind of got worried about this iris. But a lot of the time you can say to the patients, look, if your symptoms are getting worse, let me know and I can interrupt. But once you start on antiretrovirals, you've got to have a pretty good reason to stop. And detection of TB is not one of them.
Yes. No, thank you for that. There's like 3 more questions. I know you are responding to all questions alone, but I think the audience is still here. We had over 400 people. We are still at 360. So I think they are interested to hear all the engagements. Yeah. So there's a question about indications for TB culture, back so under what context should the TB culture be done? And someone was asking about sensitivities and stuff, but I think we can just focus on the clinical aspects of indications of doing a TB culture in today's era. When should we be doing that? Thanks.
So you can do a TB culture or back check on any fluid that you want, and that includes bone marrow and blood. If you are pursuing a diagnosis of disseminated TB, the yield on both bone marrow, of course, bone marrow is a bit of an invasive test, but both bone marrow and blood, that will help us pin the diagnosis. And the thing is that Mycobacterium intracellulare, I see someone's just asked a question about that. The presentation with TB and MAI is very, very similar. But if you don't start the correct treatment, so if you've got someone with anemia, hepatosplenomegaly, if you can do a bone marrow, do it. If you can't, culture their blood. And then that will, if it's negative, it means that they were not bacteremic at the time. But if it's positive and it cultures an MAI, you've got a diagnosis which will make you change your treatment.
No, thank you. Thank you for that. I think that is quite clear. We seem to get a lot of comments around the approach to INH monoresistance. And I don't know whether the questions are about the prevalence. There was one asking about the prevalence and one was asking about what to do, the regimens and stuff. Yeah, I went over it quite quickly, but I'll start again. If you make the diagnosis of INH monoresistance, you are most likely in private because it's not done in the public service. But if you do make that diagnosis, we keep the patient on INH for two reasons. One, there can be low-level resistance. And the second is that it's very difficult to get PZA and ethambutol without INH. So we keep the patient on Rifafor and we add moxifloxacin. And they should have 6 months of that. So that we keep them on all 4 drugs plus moxifloxacin for 6 months. Okay. Yeah, I've also learned something today, so I really appreciate that. I'm going to combine the question about, you had a slide about the new guidelines. I wanted, it's my personal question, to say, when are we getting the updated algorithm? But I saw there's a question as well about gene expert negative patients and the approach. So I'm not sure if there's a way to cluster this and talk to it. Thanks.
So, Lesego, you mean the new guidelines for TB or HIV?
TB. I don't know. Yes, TB, new guidelines, because you showed us quite a number of things that are upcoming. But the algorithm, because the 2014 guidelines still have the old algorithm. I know there's the LAM algorithm, which is a bit better, but I'm not sure if there's an updated algorithm or, some of us will just combine all the documents, to come up with something, yes.
So ultimately, the Department of Health will issue revised guidelines, but they take really long to do. So they'll probably, nothing has really changed in drug-sensitive TB all that much. We would like to use 3HP for the prevention of TB, but that's also seems to be quite long away. So there's the old algorithms stay exactly the same. So nothing has changed yet, except for the drug-resistant TB guidelines will be issued within 6 months.
Superb, Dr. Conradi. I think we went through a whole lot of questions, most of them, and some are just proposing that we need to look at DRTB as a talk, or even drug-induced liver injury. I see Maria Teresa there. So yeah, we will look at all those topics and see if we can get Dr. Conradi back. Dr. Conradi, in your closing remarks, you were mentioning very important things. I actually wrote here how to make TB treatment available in a treatment that is simple, that is effective, and obviously underpinning that is the timely diagnosis and the support of patients once they are on treatment. I am the president of the country. You are my minister. What are those top 3 things? I know they were there in your slides, but as part of your closing remarks, you can leave us with, if you had all the resources in your pocket and I'm the president, what would you tell me to do? I think that would close this session very nicely, Doc.
So the
Thanks.
first thing is that I would say to our previous ministers of health, you've done a good job with TB,
Yeah.
as good as possible. The fact that we use Gene Expert, the United Kingdom has only started using Gene Expert last year. We've been using it since 2010. So you've done a good job. However, we need to ensure adherence to therapy for both drug resistant and drug sensitive, which goes beyond the healthcare system and into the systematic woes of South African life. And we need to fund research. Fortunately, there are lots of, there is funding coming our way, and we need to adopt new research findings. We need to remind doctors, if I may pause for a second to tell a personal story. My father was 73 years old, and he was admitted for about 3 or 4 times with recurrent pneumonia. At the time, my baby, who is now 30 years old, was an 18-month-old infant. And of course, I went to visit my dad frequently. My baby was admitted with profound respiratory distress and had high lymphadenopathy. So he caught TB from my dad. And my dad was diagnosed after 4 admissions as having TB. So what we need to remind ourselves is that everybody who is breathing can potentially get TB. The public sector is really good at looking for it, but the private sector, they need to really be aware that anybody can get it. If you're breathing, you can get it. And we need to up our screening for TB in the private sector. I hope that covers a little bit of everybody, encouragement to everybody.